I'm hoping that we have Anne and Liz.
Yeah. So actually picking up the wonderful work that Jenny has just described, we continue here now with describing Genie, which is also based on social connections, social engagement, and leveraging resources, I suppose, for people from the community and from the people around us. So Genie stands for generating engagement in network involvement. And now I want to talk to you about what it is and how does it work. And also Liz is going to follow on by looking at the measure that we've developed alongside Genie called the Collective Efficacy Scale. We belong to a social network and health research group. And here's a lovely picture of us in our offices. But we sort of started life also in developing Genie from research developed from the National Institute for Health Research and from the European Community FP7 grant giving organisation around social networks. So actually some of our work is research based, but it brings us back, I think, to certainly the more local work that Jenny has been describing. So the aims really, just to very briefly say, is what is Genie, what does it do and how does it work, and to look at the measurement of collective efficacy. So how did we really get to sort of looking at social networks and social connections as a way of supporting people with long-term conditions? Is that actually for a long time the research and implementation group at Manchester had been following people like Jim Phillips through the expert patient program and developing all sorts of self-management support packages and looking at how the implementation of policy around chronic illness management had been implemented. And what we found out from talking to people with long-term conditions was, in terms of the support needs that they had, was that rather than identifying first off things like information or needing to access services more, although that's quite an important part of self-management, is that we started from what people expressed to us about what they valued most as they aged and accumulated long-term conditions. So we noted we did some work on looking at a loss of social status that comes from not being able to be employed and to have that daily connection to workmates and doing something of value. And what they described to us was, as well as long-term conditions being difficult to manage and needing to keep things on track, was a loss of connections to others. And this meant loss of connections to others because other people around them were ill, or friends had died also of long-term conditions, and a loss of connections through things like not being as mobile as people had been, or ability to travel. And the things that people also said that they felt a lack of connection with was the things that they'd done previously that were of value to them in their everyday lives. So valued activities, and these could be quite ordinary things about joining groups or being in the church or just going about your daily routines with some purpose and focus. And again, these things about the things that people value don't necessarily appear or are fronted up there in the kinds of patient education that was on offer at the time. Although that patient education was very useful for learning things like goal setting and how to manage your diet, for example, or exercise, it didn't really take these things about people's valued activities and their loss of connections as being central to what was on offer. There was also this thing about how an individual focus on what you can do for yourself alone is limited. That's not to, in any way to decry the efforts that individuals make, enormous efforts in actually managing on a day-to-day basis and coping. And we know people do that in a multiplicity of ways, and through an incredible amount of resilience. But it's limited because an individual focus relies only on yourself, not about who we're connected to or how those people we're connected to actually help us do things individually. So it's about moving from the individual to a more collective focus. At the same time, we were doing some research, and we have been convinced about the power of social networks, and work on social networks and who they connected to actually has been something out there in the sociological and other research about things like employment, for example, not just about health. But in terms of health, there's some evidence out there, often from public health people like Nicholas Christakis and John Fowler in the United States, who noted the way in which social networks promoted health. And it does this by providing access to social and cultural capital and assets in the form of other people, activities, information and resources. So the notion of social networks is absolutely central to Genie. At the same time, we as researchers, we wanted to look at the impact of social networks, and we did quite a lot of research. But one thing came through quite specifically in a large-scale survey, both in the UK and abroad, is that participation in community organisations is related to better health status. So that this is absolutely central to some of the things that actually Jenny and other people are doing, but it's there in the research showing that connection. And I want to say that in terms of network connections, we're talking here about mainly about human beings, but not only about human beings. It's very important also to think about other people in your network, and we talk about people in that sense as being our pets. That pets are really powerful mediators of social relationships, and they're therapeutic in their own right. We know that from the literature, but they also mediate our contact with other people. And if you go out now and you meet somebody who's a dog walker on our daily lockdown walk, you notice that you actually talk to dogs quite a lot, and then to the owner. And these things actually have proved to be, from people themselves, pets are absolutely essential. And for people with mental health problems, we also found, doing a network survey, that things and objects are very important. Newspapers, music, actual things and places. And again, these act as mediators with social relationships. And so these are things that ought to be in people's networks, and thinking about how we promote access to those networks. So I want to talk to you about Genie Talk. Based on this research about social networks, we developed an online intervention which is facilitated, that has 4 stages to it. I'm just going to, if you need more information about this, we can provide it. But the 4 elements are network mapping of the individual's current social support network using a concentric circles method. And I'll show you what that involves in the next slide. And the second one is to really look at the values and preferences for activities and support resources. So this can be health or non-health. So we said, what is it, the things you would like to do that you haven't been able to do? And it's definitely about preferences rather than a needs assessment. And there's a specific reason for that, is that people don't always want to see their focus in terms of needs in the same way as health professionals do. So we go with whatever preferences people have. And then the idea is to link individuals to a set of prioritized and valued activities and resources, which have been pre-created in a database through mapping local organizations and resources that have been categorized. And then the idea is to present these options to somebody in a user-friendly way, facilitated with clear details about access. So those are the 4 components. So here's the network map, the concentric circles, and just show it to you because its visual power is something that sort of is the engine behind making the link. And there we have Jane, who's in the middle there. And a set of questions are asked by the facilitator about who is important in your network and what do they do. So the three areas of the three circles represent areas important. So people closest to Jane, John, is the most important person, along with Emma, the friend. And in the second one, we've got the neighbour, and in the outer one, we've got the nurse. And the idea here is to reflect on your network and who you have access to and what they do for you, in order to think about your options for connecting to further resources, and what you do need and don't need in your daily life for managing linked into your local community. So what does Genie do and how does it work? So by focusing on a network, we think it provides a sort of positive disruption to your existing practice. Some people would say a kind of like nudge, or a kind of a reframing of something, because it's asking the person to look away from themselves to who's around them. We're not asking them how motivated they are or what they should be doing. And we find this externalizing away from the self to mapping who is around you and who you connect to is actually a positive way of moving on to seeing what might be possible for people in terms of self-management options. And this is partly done through visualization, and hence the online thing is quite important. The network, seeing who's in the network and who you can move around is really important. It's also important for visualizing and reimagining what's possible for you in your life. It also operates through a mobilization of network resources very locally. Issues to do with proximity are really important. Although we talk a lot about online resources, actually it's very important for people to be able to access offline help and support in a very immediate situation. So the mobilization of network resources and the possibility of doing that very locally is really important, as is the engagement with new or renewed activities through the database. So through people's preferences, they can look what's on the database and then choose to actually go on to do those activities. And the other thing that's important is mediation, a facilitation. No, it can't just be used online without somebody there to help people talk through the options. Very important, that element. So that's how we think it works. So this one is about collective efficacy of networks, which is the measure that we've developed alongside this. And for this, I'm going to hand over to my colleague, Liz James, who is going to actually talk you through the slides.
Thank you very much, Anne. As Anne's presentation has indicated, our social networks, our social relationships, if you like, play a really, really important part in how people both create and I suppose maintain healthy lifestyles, and they really enhance our both physical and mental well-being. But as Anne said, it's not just about the individual. We became very interested in the collective process that is going on, and as opposed to the term self-efficacy, where the emphasis is on the individual's personal sense of confidence and control in relationship to their health. The term collective efficacy is really looking beyond that individual self-management support and exploring what happens within our whole personal communities in relation to managing health and well-being. So by personal communities, we simply mean the collection of connections, relationships, and relationships that are important to us in some way, that are meaningful. And these are where people are linked together, perhaps through patterns of commitment, social relationships, and they're linked to friends, family members, acquaintances and neighbours, and as Anna suggested, pets also play an important role here. So we became very interested in how people relate to one another across these many different social relationships, offering different types of support, even within a network. Support could be practical, helping with household chores maybe, or support could be more emotional, sitting, talking, listening to people in your network. And we became curious as to how we could actually try and capture this notion of collective efficacy and somehow measure it. And since our research had already shown us that asking for and providing support from the people around us is far more complex than it appears on the surface. It often involves effort, and it can change over time depending on how and when we interact with the people around us, in order to both give and receive support and help. And this sort of effort that we all make in our different ways can be described as relational work. And we found that this relational work is really key to understanding how and if and when we access the support that we need. Questions that came up like when is it okay to ask for help to meet our particular needs? Who do we turn to? And why do we turn to some people and not others, depending on the needs at the time? And how do we do that? The negotiation, I suppose, is the way that you're finding your way to the right person to have the right conversation in asking to support. And sometimes asking for help also depends on whether you feel you have something to offer back, to give back. So that sort of give and take balance that leaves you feeling good inside, feeling valued, being able to give and take and reciprocate in some way, we found to be an important ingredient in some of that relational work. So we wanted to extend this previous research that we've done around collective efficacy, and we undertook this new piece to measure this notion of collective efficacy. And we did this within personal communities and in relation to managing a long-term health condition. And we wanted to pay particular attention, I suppose, to the relational work I've just talked about. So we knew there are existing self-efficacy and social support measures, but we thought we might find some overlap with these measures, and maybe we could use them together in combination with a collective efficacy measure. And we also hope that a new measure might help us to predict some of the important health outcomes beyond those existing scales, particularly interested in physical and mental health outcomes and also loneliness. So I won't go into great detail about the research methodology, but I think it's important to say that in terms of patient involvement and empowerment and community empowerment, we have three different sort of phases of data collection in which people helped us, people living with one or more long-term health condition, and they were deeply involved in generating these phrases, these terms, the way they described what it was like to live with their condition, what it was like to live on a day-to-day basis. And we did this through focus groups and different groups who shared with us. And in order to sort of use words that were meaningful to people who were actually experiencing a long-term condition. So we generated these words, these items, and then groups of people helped us to refine and modify them through discussion. The end product of the measure that we came up with, the SENS measure, it contained 12 items, so 12 phrases that had been generated by the people we worked with. And these sort of fell into two categories: network responsiveness and access to collective efficacy. And these reflected two really distinct aspects of collective efficacy. And by network responsiveness, we found that items in this category were to do with how a person perceived their network and how they saw their network's collective efficacy. Is your network able to understand and respond when problems arise? Are people around you aware of what you need, and are they sort of in tune with your needs as these needs change over time? How reliable or trustworthy is your network? And can you rely on and trust people to support you when and how you need support? And we found that this particular category, network responsiveness, these are items that were linked to the existing self-efficacy and social support measures. And they also acted as a predictor for loneliness. So we were quite excited about that. And the second category, the access to collective efficacy, these items were really about somebody's perception of being able to tap into their network. So in other words, the extent to which they felt able to ask and negotiate for support and get the sort of network support that they needed. So how people perceived their own ability to access it. And it also touches on how we're able to accept support and help. And these items seem to fall into a category that significantly predicted better mental health. So these are just some of the examples of the items that people helped us to come up with, which form the measure. And it's provided us really with a validated way to both assess self and collective efficacy, like together. So it's really enhanced our understanding of health and behaviour.
To finish off, and I'm not going to go through it because we're over time, but it just provides a little bit of summary about what Liz and I have just talked about. And there isn't the extra information there about that it has been shown to be cost effective using that, which policymakers do still focus on, even though we focus on the needs of people more than that. So that's just a summary slide of our work. And following on from that, a few references if you're interested in following up our work. And in particular, I've just highlighted the one Kennedy et al. Because that provides a full description of Genie and its implementation. So you might, if you want one paper to go to, I will go to that one. Thank you for listening to Liz and myself.